kg, or maybe the Holter test could show a temporary change in the ACT segment. What is the capacity of coronary angiography, which is only seeing the light of the vessel, to help us decipher what's happening with patients who have stable angina or acute syndromes? The patients involved in these problems of angina with normal coronary angiograms could have epicardial coronary spasms, coronary bridging, coronary slow flow, Takotsubo cardiopathy, and coronary microvascular dysfunction, which could be primary or secondary. This is going to produce stable microvascular angina or unstable or acute MVA, which could present as acute coronary syndrome and could lead to acute MI, which is also known as MINOCA. And the importance of this is the statistics, what they show. This shows what's been happening with the reports of angiographies in men and women, and how throughout the years there's an increasing level of reports of coronary angiographies showing healthy coronary arteries, free of significant disease. And if we sum up these two graphs, we can get nearly 50% of patients with stable coronary disease to develop arteriography without significant obstructive disease. This also happens at the level of the acute coronary syndrome. As I was telling you, the MINOCA, as I was saying, it's a recently coined term. It's a work diagnosis which means myocardial infarction with non-obstructive arteries, and it represents all these criteria, but the ischemia has positive troponin. So it coincides with the universal definition. With positive troponin, there is no obstruction beyond 50% of the artery diameter, and there is nothing else explaining it.
So we are facing a microvascular dysfunction and a microvascular commitment that could show stable charts and unstable charts. So why do we have this large proportion of coronary arteriographies charts that don't show any obstructions? When we are looking at coronary obstructions, we are looking at it with an resolution of more than 500 microns, so we only see this. So the coronary situation is actually this, which means that we're just looking at a small fraction of what is happening with the circulation of the coronary arteries. But most of the circulation and the largest phenomena that we have for the perfusion of the myocardium is happening in all this network that is shown in this slide. And this behaves functionally in the following way. In the epicardial arteries, the ones that we are used to seeing and treating for coronary diseases, only contribute to 10% of the coronary resistance and only contain 5% of the blood volume in the myocardium. The most important part of coronary resistance lies in the microcirculation between arteria, and they account for 80% of the coronary vascular resistance. And Most of the volume of coronary arteries are located in this network, which is in a network of capillaries. So traditionally, and because of the capacity of looking at coronary arteriographies, we are focused mostly on epicardial coronary arteries, but we cannot disregard everything related to the microcirculation that generates more than 50% of the events in patients with stable coronary diseases. So this is also represented in this chart. We see how the pressure is dropping, intracoronary pressure in the different segments of the coronary circulation. In the epicardiac arteries, how they affect pressure, and from then on, the great coronary resistance is spread throughout the microcirculation all the way to the coronary sinus. And all this function of this microcirculation can be measured. We can measure it in this chart. For example, we see that in the absence of coronary stenosis, in a normal person who is administered denosins is capable of increasing the coronary flow from 34 times. But if the patient has a microvascular dysfunction, we have the same test with adenosine, and we see that it increases a little bit, but then it becomes stable. So this is the coronary flow, and I will explain that maybe this patient can be walking, they do angina, they have a ischemia provocation test, and they go into nuclear medicine, and we can see patches in the patterns of hyperperfusion in nuclear medicine, and in the electro we actually have SCT segments. But this is also similar, this microvascular dysfunction. It's similar to what happens in the distal segment in the coronary artery that has a proximal stenosis. If we have a proximal stenosis in the artery from then on, it's using its whole capacity of coronary vessel dilation capacity, while this artery doesn't have any obstructions. So the behavior is very different in comparison to the increases of cardiac frequency, because the higher the cardiac frequency in a segment of artery that is normal, we can see how the resistances fall and the capability of the myocardium perfusion is higher. But this is contrary, because if we have microvascular hyperfusion, the more cardiac frequency we have, what we see here is that the resistance is going to increase and the perfusion of the myocardium is insufficient, and this ends up creating angina in the patient, or for him or her to have an acute coronary picture. As for coronary dysfunctions, microvascular dysfunctions, the reasons for this can coexist and they can also be different. And an important aspect in microvascular dysfunction and for the treatment of microvascular dysfunction is to treat the risk factors, because these risk factors, hypertension, diabetes, smoking, and all of that, they create dysfunction of the endothelium, and based on this we will have the microvascular dysfunction. But this is not the only factor that affects the microvascular dysfunction. We have also seen that there could be an autonomous imbalance between the energetic and the parasympathetic things. So we can see a patient that can have a reduction in the parasympathetic tone, and they can have constriction or sustained spasms in their microcirculation. There are also independent mechanisms that depend on the endothelium, and they produce a flow, a blood flow, in response to the acetylcholine and stress with cold, and the independent symptoms of the endothelium can be compared in blood fractions, coronary fractions, or in response to endosine and periodontal. And in addition, the coronary arterioles can be seen, and we have seen that this adenosine can actually affect the perception of pain and make these patients to be more susceptible to symptoms. This is truly more applicable in women. So the consequence of all these risk factors that I just mentioned, with factors like hormonal changes and obesity are going to take two paths. They are either going to produce a coronary atherosclerosis, or we don't actually know what is acting right now, so that a patient has the formation of plaques, or that they have a microvascular dysfunction. And this microvascular dysfunction will cause myocardial ischemia in the patient, or that they produce cardioempathies or ventricular dysfunctions. This is especially in patients with ventricular hypertrophias, either through hypertension. If they go under these tests to look at the micro dysfunction, and we'll look at the vessel circulation, a person with hypertrophic cardiopathy, we can see that the response in these patients or using adenosine is reduced, and the patients with left ventricular hypertrophy, for example, for arterial hypertension, we can see that it's completely reduced in comparison to normal people. And in hypertrophic cardiopathy, all this problem with microcirculation and microvascular dysfunction with microvascular remodeling and cardiovascular fibrosis, with all the changes that are going to compress this microcirculation, are going to lead to the production of myocardium ischemia, and this is going to produce fibrosis. And in some nuclear medicine, we can see that this is going to cause a remodelation of the left ventricle with sudden death and arrhythmia. And as you can see in the initial phase of this process, we have the vascular sections in which the histological cuts or slices, we can see the density of the capillaries of a patient in a patient or a normal person in comparison with the density of capillaries of a person with a hypertrophic myocardiopathy. So this shows that in the MRI studies, we can show the characteristic aspects of the perfusion areas of the MRI, and in the late images, we can see the fibrosis that we see in the secondary ischemia in hypertrophic myocardiopathy. So this is also responsible for most of the myocardium ischemia pictures. These are the traditional mechanisms that we know of, and these are the microvascular mechanisms that are going to allow us to have an alternate coronary physiology. Because of the reduction of the microvascular circulation, that is going to lead to ischemia, coronary disease, or cardiopathies, and at the same time, this is a factor that is certainly implied in the pathology of the Takotsubo syndrome. When we look at patients with coronary disease, the coronary disease of a patient doesn't just depend on one factor like the obstruction of arteriosclerotic plaque, or that it is just related with a spasm. What these studies have shown is that all these different factors that contribute to the ischemia and the myocardium are seen in greater proportion in the population of coronary diseases. And ischemic stable coronary diseases have been seen from a different perspective, in which it is not just caused by the problem of epicardiac arteries that prevent the flow because of stenosis, but that the microvascular structure that could be conditioned by the arteriosclerotic functions and spasm of the microcirculation, which is different than the spasm in the epicardiac arteries, and inflammation like dysfunction at microvascular level, for example, for transplantations in patients or patients with collagen diseases, and microembolisms, as we can see in people who have hearing diseases after coronary interventions, or capillary diseases like the one that I showed you in the histological pictures. The density of capillaries actually lead these types of coronary ischemic diseases. And also the microvascular dysfunction is caused by structural situations, functional and extravascular situations, or the combination of several factors in the same person. Structural ones, this is where we can obstruct the flow of the microvascular structure through the blood vessels. We will have an implication of the muscle walls, which is what happens in Fabry, for example. We are going to have a remodeling, a reduction of the muscle density in hypertrophic myocardiopathy. And there are also causes or functional alterations that I just mentioned about the dysfunction of the muscle cells or the dysfunction, autonomous dysfunction, and there could be also extravascular situations that are the compression, for example, if we have hypertrophic ventricles, or the reduction in the diastole time of the ventricles. So this leads to have a clinical spectrum of the microvascular dysfunctions can be behaving like spasms because of the expansion of the vessel constriction stimuli, and it can be shown with exercise and with depression because of microvascular spasms, and it could be permanently in rest because of a basal microvascular constriction, or it could have a vessel dilation response for exercise in relation to patients that have angina with effort, or it could have a constriction vessel symptom in the patients. As for the assessment of this microvascular dysfunction, we first have to take the patients who have positive troponin. We cannot find coronary lesions that are obstructive. And how can we address a patient like this? First, we have to think that a patient that has another case or cause that increased. For example, an MRI could give us a diagnosis, and we can think that they don't have pulmonary embolism as well. It could be an infarction, type 2 infarction, that could be an imbalance between the contribution and the demand of oxygen, and we see that the patient is not suffering from hypertension. So in a case like this, we could actually go into invasive studies. And finally, after thinking that it wasn't any of those causes, we could start thinking that maybe this patient who had an infarction of the myocardium without obstructive coronary diseases could actually have a microvascular dysfunction, for which we could also use invasive procedures for the assessments with intracoronary Doppler. So how do we conduct this assessment? We do this through the coronary reserve flow, which is the relationship between the hyperemic phase and the basal flow base in a coronary artery. So this is the relationship of what we can do through pharmacological tests with dipyridamole or adenosine for the independent adaptation of the endothelium, or with the cold test for the vessel dilation depending on the endothelium. We consider that reserve of coronary flow of less than 0.5 could be considered as a microvascular dysfunction. And if these tests are not sufficiently explanatory of the things that are happening, then we recommend to attach coronary spasms tests. So these measurements of this hyperemia flows, how do we do this? With images. It could be through the Doppler, which is mostly more available to do. However, the capacity to determine more details of the function is not as good. We could also use echography with contrast. We could use depth, which shows us more capacity and precision and accuracy to determine this microvascular function. However, we have an increase in cost, and it depends on availability. Or we could also do it in an invasive way through the catheters of intracoronary Dopplers, in which we can conduct the measurement before and or after the vessel dilation stimuli. As I said, from the non-invasive perspective, maybe PET is the most accurate method, It has a very good accuracy, and it's quite effective as well in terms of results, but we require these aspects that are probably not available in the region to conduct these PT studies in this way. As I said, the other method, which is non-invasive, which is not always the nuclear MRI, which is the early and the late enhancement with these images. So what are the aspects of these tests? These are just 2A or 2B. These tests are not recommendation number 1, even though there are some class 1 recommendations in some specific situations for tests that cause spasms for patients that have the characteristics that are shown here. This microvascular dysfunction does cover a wide spectrum of circumstances. Of course, not all of this can be grouped into one single basket. So there is a clarification that tries to explain what happens in each patient, and the microvascular dysfunction, which is type 1, it's known as syndrome X, which is the patient who has angina. There has a confirmed ischemia, but they don't have any other associated diseases, but they do have the risk factors. So this is the classical case. And also the type 2 microvascular dysfunction is associated to the fact that the patient has a myocardium sick, and it could be determined because of hypertrophy, dilated cardiopathies. And type 3 is the microvascular dysfunction in patients that have coronary disease, and type 4, which is the one that is produced when we rechannel and we create a distal embolism, and we have a reaction of, this is normally a type 4 microvascular dysfunction. And we are about to establish a type 5, which is the one that we have after these myocardium transplantations. As for treatments, there isn't a specific treatment. The most important thing is the control of the risk factors to try to remove angina in the patients, and the usual anti-ischemic treatment through the mechanisms that we have, in which we have nitrates produced in some patients, but for many other patients which are at another level, the nitrates actually don't work. And if the patient continues with angina, we could actually test or try some of these anti-angina substances. And if this doesn't work, we can use external counter pulsations or with spine pulsations. But as I said, the most important thing in this dysfunction, microvascular dysfunction, is to try to have prevention, because there isn't a specific treatment for this. And the prognostic will depend on every type of diastolic dysfunction. If it's type 2, 3, and 4, it depends on what is producing it and the treatment that is being tested. But as you see, most of the results of the impact of these treatments in the diastolic dysfunction are actually unknown, and there are very few that have documented and show that they are useful. So in conclusion, this is a macro problem that we are facing, and I think that is not addressed sufficiently in our daily practice. This leads to many types of alterations in the coronary flow, which are shown as coronary syndromes, acute coronary symptoms, or as stable angina pictures, because these risk factors, some patients in coronary diseases actually lead them to microvascular dysfunction. We don't actually know. The prognostic depends on the pathogenic mechanism that is being produced. About 20 to 30% of the patients, despite everything that is done, they experience a progressive worsening, and these are patients who go to 100 consultations in the ICU and 20 different consultations for a specialist, and they have repeated exams for 10 times that probably do not contribute with any additional information. These are patients that are very hard to handle. So how can we distinguish between the microvascular dysfunction and coronary diseases to prevent all this amount of unnecessary exams? We still have to determine this. And of course, we need studies to identify the subgroups that are under highest risk suffering this disease. So this is the message that I wanted to convey and to show you that this causes 50% of the stable angina cases. And in nuclear medicine, you report that there are ischemia areas, and these areas of ischemia, when you interpret them, before you think if the catheterization had normal coronaries and there was a false positive, well, maybe we have to think that it's not a false positive, but it is actually, we need more specific characterizations for this patient because there are other microvascular dysfunctions that are generating these abnormalities in the perfusion. Thank you very much.